welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next presenter is going to be Gabrielle Jones. She's currently a PGY2 emergency medicine resident at Massachusetts General Hospital. Today, she's going to be presenting a journal club on the safety of Diltiazem for acute management of AFib in patients with heart failure and reduced ejection fraction in the ED. Thank you.
These are some following abbreviations that I'll be using throughout the presentation. And getting into the background of AFib, AFib is the most common sustained arrhythmia with an increasing prevalence in the United States and globally, and it's expected to rise by 12.1 million cases in the United States by 2030. It accounts for over 450,000 admissions in the United States, and 70% of ED visits for AFib result in hospitalization. One of the most important things is that AFib is common in heart failure patients, and heart failure predisposes AFib and vice versa. The prevalence of AFib ranges up to 50% in HFrEF and 65% in HFpEF, so we do see more of an incidence with our preserved ejection fractions. And despite high admission rates, overall ED mortality among patients with atrial fibrillation is low. MGH, AFib with RVR, is one of the most common presenting conditions. And as emergency medicine pharmacists, we need to be aware of how to effectively treat these patients with AFib and fast ventricular rates when they present to the ED, especially in a population such as heart failure, where AFib and heart failure commonly coexist. So in a normal heart, bringing it back to pharmacy school, the SA node is a predominant pacemaker with automaticity and initiates an electrical impulse, which travels to the AV node, bundle of His, left and right bundle branches, and then the Purkinje fibers, leading to a ventricular contraction. So in AFib, on the other hand, there are ectopic atrial premature beats that are initiated, and they initiate electrical impulses, which typically arise from these myocardial cells that are close to the pulmonary vein and atrial junction. And although these atrial ectopy may initiate AFib, persistence of AFib is often due to disease-specific atrial electrophysiological or structural changes that trigger abnormal automaticity and re-entry circuits. What's characteristic of AFib is that on an EKG, P waves will not be distinct. This is because when atria are depolarizing, there is no uniform depolarization due to the abundance of firing foci due to this automaticity and re-entry circuits. So some action potentials will eventually make their way through the AV node, causing ventricles to contract in an irregular manner, which we will then call a ventricular response. AFib with RVR is usually a manifestation of AFib when the heart rate is above a range of around 110 to 120 beats per minute, but there is no predefined heart rate for RVR. Most people just use a threshold of around 100 to 120. Risk factors for developing AFib are advancing age, smoking, hypertension, diabetes, mitral valve cirrhosis, structural heart disease such as heart failure, CKD, among others. And these are linked to or are chronic disease states that will lead to these electrophysiological and structural changes in the atria. So basically, this leads to atrial stretch, and that leads to an increased left atrial pressure, and this promotes the initiation and persistence of AFib. We also have provoking triggers that can initiate AFib, such as infection or sepsis, bleeding, hypovolemia, hyperthyroidism, or stimulant use. And these cases would be called unisolated AFib, since there's no provoking factor. It is a provoking factor of illness, and it's not due to a primary cardiac dysrhythmia. However, both can coexist. Treatment of provoking factors such as reversal of blood loss by giving blood may be enough to convert someone back into sinus rhythm without the use of rate or rhythm control. AFib can be treated in the ED by two ways pharmacologically, rate or rhythm control. In rate control, we maintain the atrial arrhythmia, but we suppress the ventricular rate, while with rhythm control, we would convert to normal sinus. There are various reasons why you would want to choose one over the other, but that is beyond the scope of this presentation. The aim of rate control in AFib with RVR is to reduce symptoms, improve hemodynamics, prevent heart failure, and to reduce the risk of any adverse cardiovascular outcomes. There are two main guidelines that we'll go into. First, we will go into the AHA, atrial fibrillation guidelines. So they recommend an IV beta blocker or non-DHP calcium channel blocker in hemodynamically stable patients for rate control, provided that their ejection fraction is greater than 40%. They also mention patients with AFib RVR with known moderate or severe left ventricular systolic dysfunction with or without decompensated heart failure. Non-DHP calcium channel blockers should generally be avoided. And their reasoning behind this is due to the presumed limitation of negative inotropic effects. And they do admit that this is limited data in the HFrEF's population to support this. So we will go into retrospective studies and slides coming up that basically support these recommendations. AHA and ACLS guidelines came out last month, and they also mention rate control for atrial fibrillation. They recommend IV beta blockers and non-DHP calcium channel blockers to slow ventricular rate in patients with AFib and preserved ejection fraction. And then they also mentioned IV beta blockers and non-DHP calcium channel blockers should not be given in patients with left ventricular dysfunction and decompensated heart failure, as this may lead to hemodynamic compromise. Both of these guidelines in particular do also mention that amiodarone can be given as a rate control agent in decompensated heart failure. And usually in the ED, we'll see that as like a 150 milligram bolus. So diltiazem is a non-dihydropyridine calcium channel blocker, which means it inhibits L-type voltage-gated calcium channel blockers in the heart and smooth muscle during membrane depolarization. And these have effects on chronotropy, inotropy, dromotropy, and peripheral vascular resistance. With chronotropy, it decreases SA node automaticity. With inotropy, it decreases the muscular contraction. With dromotropy, it slows down the conduction at the AV node. And with peripheral vascular resistance, it relaxes vascular smooth muscle and can cause hypotension. What we're most concerned with inotropy is that it decreases muscular contraction, and that is concerning in heart failure patients. Interestingly enough, I was looking into the FDA package insert for IV diltiazem, and they do mention that there really is a limited number of studies that patients with compromised myocardium, such as heart failure, acute MI, hypertrophic cardiomyopathy, patients like these who've received IV DILT, they actually produced no significant effect on contractility, and there was no difference in ejection fraction or cardiac index. Some people even had a better cardiac index after IV diltiazem. But there are rare case reports of worsening congestive heart failure in patients with pre-existing impaired ventricular function. And it's also important to note in the pharmacokinetic section of this FDA package insert, maximal hemodynamic effects would occur within 2 to 5 minutes after the injection. So where is this evidence for diltiazem harm coming from, besides just thinking about it mechanistically through negative inotropy? First, there was a trial called MD-PIT done in 1991. It was a randomized, double-blind, placebo-controlled trial comparing diltiazem versus placebo 3 to 15 days post-acute MI. And what they found was increased progressive impairment of baseline ejection fraction and greater occurrence of late CHF in diltiazem group. So basically, these patients were followed 3, 6, 9, and 12 months after their randomization, and they were being evaluated for orthopnea or like pulmonary rails, and that would be considered a late CHF outcome in these patients. It is important to note that this was with chronic use of diltiazem therapy and not just like a one-time dose of diltiazem. The AHA has released a scientific statement of drugs that may cause or exacerbate heart failure, and they do mention diltiazem. They mention that it exacerbates underlying dysfunction through its negative inotropy, and then it's a major magnitude of heart failure induction or precipitation. The onset would be immediate to intermediate. Looking at literature review for evidence for harm, the first study we'll talk about is Jindali and colleagues, which looked at heart failure patients with an ejection fraction less than 50% versus 50 or greater percent with AFib with RVR or flutter, who received a continuous IV diltiazem infusion. What they found was that patients with an ejection fraction less than 50% had longer lengths of hospitalization and higher rates of AKI. There was no difference between hypotension, ICU transfer, or mortality. One could argue that these are still like clinical impacts that may be due to diltiazem. Again, there was no comparator arm, but these may not be super meaningful in terms of heart failure. The second study we'll talk about is done by Hasbrook and colleagues, which looked at patients with AFib RVR who received either IV DILT or metoprolol within 12 hours of arrival and had a documented ejection fraction of less than or equal to 40%. So these patients who received diltiazem had more worsening of congestive heart failure symptoms compared to metoprolol within 48 hours. But why is diltiazem an attractive rate control agent? Why would we want to use it? There have been multiple meta-analyses showing better rate control with IV DILT compared to IV metoprolol. In the first meta-analysis that we'll talk about done in 2022, they found that patients treated with IV DILT had a higher achievement of rate control compared to patients treated with IV metop. Their target rate was less than 110 within 6 hours of IV metop or DILT, and they also found no difference in adverse effects with hypotension or bradycardia. In the second meta-analysis done in 2024, they found that IV DILT was also found to be more effective than IV metop for heart rate control. Their heart rate target was less than 110, or a decrease of 20% from their baseline of initial presentation, all within 6 hours or less. They also found faster rate control with diltiazem as well. This was not reproducible when they only looked at observational studies. Looking at evidence for no harm, we have a study by Compagner and colleagues which compared AFib with RBR patients treated with IV metop or DILT who had documented heart failure and an echo done within the past 12 months. What they found was that diltiazem had larger reduction in heart rate at 30 and 60 minutes after admin and a faster time to rate control compared to metoprolol. There was no difference in adverse events, hypotension, shortness of breath, vasopressor use, or a change in ejection fraction in a subsequent echo. A special part of this is that a majority of these patients had HFpEF. Around 20% had HFrEF. There was a sub-analysis group for HFrEF, which did show still a greater heart rate reduction with diltiazem. However, they did show a greater ejection fraction improvement with metoprolol. That would not discount that diltiazem also had an improvement with ejection fraction as well. So it's not that it actually decreased the ejection fraction. The last study that we'll go into is done by Capistova and colleagues, which looked at patients with AFib with RBR and treated with IV DILT or metop and had a documented ejection fraction less than or equal to 40 prior to their first DILT administration or metop. Found no events of hypotension, bradycardia in either group requiring the use of vasopressors or inotropic agents within 60 minutes of administration. That leads us to our study. This is safety of diltiazem for acute management of AFib in patients with heart failure and reduced ejection fraction in the emergency department. This was published in the Journal of Emergency Medicine in June of 2024 by Schmidt and colleagues. The study objective was to identify signs of worsening heart failure in patients known to have a reduced ejection fraction in comparison with patients with a normal ejection fraction after receiving IV DILT for acute AFib with RBR management in the ED. This was a retrospective single-arm cohort study at Mayo Clinic of adult heart failure patients presenting with AFib with RBR that received DILT in the ED from 2021 to 2022. These patients were included if they had an echo within 5 years prior to the ED visit. They also were included if they were receiving oral DILT as a continuation of home therapy or an oral overlap after their initial IV therapy. They excluded patients with A-flutter or patients who did not have an echo within the past 5 years. While I think this could also be used in the results, I think this really helps explain part of the study design. There was 822 patients identified with the data pool, and then they excluded patients who did not present with AFib. Overall, 708 patients were screened, but then they excluded patients with no echo within 5 years and no diltiazem in the ED. Overall, they included 386 patients in this study. However, for the primary outcome analysis, they did not include patients who were discharged straight home from the ED. For secondary outcome analysis and subgroup analysis, they did just include everyone who was included in this study. For study endpoints, the primary outcome was a composite outcome of worsening heart failure, which is defined as development of cardiogenic shock, initiation of BiPAP or mechanical ventilation, initiation of vasoactive agents, cardiac arrest, and death. Again, patients discharged from the ED were not included in this outcome. Secondary outcomes include return ED visit within 7 days, death within 7 days, and disposition from the ED. For statistical analysis, it is important to note that most of this data is descriptive because there is technically only one arm. For continuous data, they did median IQR. For categorical data, they used frequency or percentages. They did do subgroup analyses of the primary and secondary outcomes among patients with an ejection fraction less than 50% or greater or equal than 50%, patients discharged from the ED based off age and sex, as well as a subgroup analysis with a cutoff point for ejection fraction of 40%. They used inferential statistics to compare these subgroup analysis using Wilcoxon rank sum as well as the Fisher exact. Again, it is important to note that the study was not powered to detect differences between subgroup analyses or even powered in general because the primary outcome had no comparator arm. And that brings us to results. For patient demographics, patients were 72 years of age, a little over half were male sex. Most patients were white and not of Hispanic or Latino origin. They weighed around 86.8 kilograms. Most patients had a past medical history significant for AFib, and only around 15% had a recorded history of congestive heart failure. Median ejection fraction was 60%, and only 13.7% of the patients had an ejection fraction less than 50%, meaning a large majority of these patients had HFpEF. Most of these patients got at least one diltiazem dose, with most of these being an IV diltiazem dose. The time to the first dose was a little bit over an hour and a half. The first diltiazem dose was around 10 milligrams, and we think about the patient demographic weight of 86.8 kilogram dose. This is a little bit about under half of what a weight-based dose for atrial fibrillation would be. It kind of makes me think that they were doing fixed dosing at Mayo Clinic. Around 20% of these patients received a beta blocker, and around 3.2% of these patients received amiodarone. Again, primary outcome only included patients who weren't discharged home from the ED. Around 6.8% of patients met the primary outcome for worsening heart failure within 24 hours. And the main drivers of this were initiation of BiPAP, initiation of vasoactive or inotropic agents, and death. The secondary outcome included all patients. Around 6.7% of patients returned to the ED within 7 days. 1.6% of patients experienced death within 7 days. And what's interesting from this, thinking about it from a disposition standpoint, is that a little over one-third of these patients were discharged home from the ED. The rest of these patients were discharged to either a medicine unit that had cardiac monitoring or no cardiac monitoring. 7.3% of these patients were admitted to the ICU. The rest were admitted to some observation unit, whether it be the ED obs or hospital observation. And then I think the most important subgroup analysis from the study is the comparisons between ejection fraction. So in the subgroup analysis comparing ejection fraction less than 50 and greater than or equal to 50%, they found worsening heart failure and death within 7 days, which is more in the ejection fraction group that had less than 50%. But it's important to note here, especially with the asterisk next to the worsening heart failure group, this is because they didn't include patients who were discharged home from the ED, which is similar to their primary outcome. And again, in those first two, worsening heart failure and death within 7 days, they found this to be significant. In the subgroup analysis comparing ejection fraction cutoff at 40%, there was no difference between ED return visit within 7 days or death within 7 days. And again, this study was not powered. So that takes us to our conclusions. So first, we'll go into the author's conclusions. They state that among patients admitted to the hospital, worsening heart failure was observed in patients who received DILT for AFib with RVR and had a documented ejection fraction less than 50%. The pathophysiology of AFib is heterogeneous, indicating that not all patients with heart failure are equally at risk for decompensation after DILT administration. And what I think is really interesting is in their discussion section, they mentioned that they went through all the cases that had a worse outcome. And all of those patients had some sort of underlying disease process in addition to AFib that may have been causing worsening heart failure. And these conditions included sepsis, pneumonia, renal failure, non-cardiac respiratory failure. And because of this, they recommend individualized assessment in considering other risk factors for adverse outcomes before using DILT in patients with heart failure with reduced ejection fraction who are requiring rate control. For my critique, there are strengths to this trial. This is a real-world ED cohort reflecting current practice at a large AMC such as the Mayo Clinic. It includes a subgroup analysis of patients with HFrEF. It has clinically meaningful outcomes for worsening of heart failure, such as in the primary composite, they do include cardiogenic shock, cardiac arrest, initiation of inotropic agents. However, this study does have also some limitations as well. So the ejection fraction documentation that was taken within 5 years may not be reliable, as we know that ejection fraction can be changed within 5 years. Did not account for confounding factors such as infection. It was not powered. This is mostly descriptive data. And then again, this is a single treatment arm with no comparison to other negative inotropes, such as metoprolol. The composite primary outcome can also be driven by other underlying illnesses, such as death, other vasoactive agents. They did include vasopressors that didn't have any inotropic activity, and they didn't tell us a dosing of such as epinephrine. So I don't know if they were using it at inotropic dosing, as well as mechanical ventilation or BiPAP. Also, again, this is mostly HFpEF patients. There was a letter to the editor published in the Journal of Emergency Medicine in response to this article that shared similar critiques, such as reliance on an alt echo may not currently reflect current cardiac function. There is really a small proportion of patients with reduced EF. That amount of patients was 13 in the whole entire study. So this limits the statistical power in the subgroup analysis. There's no adjustment for confounders such as sepsis, renal failure, pneumonia, and really the lack of control group really diminishes our ability to apply these results because of diltiazem. We don't know if this is because of diltiazem. However, again, this study did provide some valuable insights with diltiazem in patients with reduced ejection fraction, but really we need a large randomized controlled trial to assess long-term complications and clinical outcomes. So for my conclusion, worsening heart failure was observed in those who received DILT for AFib with RVR and had a documented ejection fraction less than 50 in a subgroup analysis. In the subgroup analysis with an ejection fraction cutoff around 40%, there was no difference in death. These findings should be viewed as hypothesis generating as the study was not powered. The decision to use diltiazem in patients with heart failure should be patient-centered and recognizing if AFib with RVR is being caused by an underlying process such as sepsis, renal failure, non-cardiac respiratory failure. And because of that too, prospective multi-center studies with diverse populations are needed to further address the safety of diltiazem for the treatment of AFib with RVR in patients with heart failure, especially patients with HFrEF. And if we do a randomized controlled trial, these studies would definitely need propensity matching for underlying illness such as infection, sepsis, or malignancy. With that, here are my references, and I will take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.